and I will introduce our panelists. So with me is my colleague, Dr. Sheldon Horowitz. He's the Senior Advisor of Strategic Innovation Research and Insights at NCLD. He provides leadership and oversight of key programs and serves as our in-house expert on all things learning and attention issues. Prior to NCLD, he was served as the Associate Director of the Learning Diagnostic Center at Schneider's Children's Hospital in Long Island. And before that, he was Assistant Unit Chief Educational Supervisor and Grand Rounds Chairperson of the Center for Mental Health Department of Psychiatry at Interfaith Medical Center in Brooklyn, New York. Wow, that was a mouthful. With us is also Dr. Lerner. He is a pediatrician who specializes in developmental and behavioral medicine and is active in the Orange County's chapter of the American Academy of Pediatrics. He's a fellow at AAP as well. He was the chair of the executive committee of the National AAP Council on School Health and continues to teach and practice pediatrics at UCI's Center for Autism and Neurodevelopmental Disorders. Dr. Lerner serves as a school medical consultant for school districts in Southern California. Before we get started in the discussion, I wanted to say a little bit about NCLD and learning and attention issues and how we are working to detect these early on in a student's development. So first, NCLD's mission is to improve the lives of the 1 in 5 children and adults nationwide with learning and attention issues by empowering parents, young adults, and transforming schools and advocating for equal rights and opportunities. We're working to create a society in which every individual possesses the academic, social, and emotional skills needed to succeed in school, at work, and in life. NCLD was founded in 1977 as the Foundation for Children with Learning Disabilities. In 1989, the organization evolved from a foundation into a nonprofit and expanded its mission and scope of work and changed its name to the National Center for Learning Disabilities. Today, more than 40 years later, NCLD continues to lead in the field of innovation and research and advocacy on the national level. A little bit about learning disabilities and attention issues. These are brain-based difficulties that affect the brain's ability to receive, process, store, respond to, and communicate information. They can impact many areas of a child's development, such as listening, speaking, reading, writing, reasoning, and math skills. These individuals are just as smart as their peers, but may struggle with reading and math. But with the proper supports, we know that these individuals can succeed in school and in life. So one of the things that we've seen a lot is that many preschoolers and school-age children struggle with learning and attention issues, but it's not often able to be determined if it's a learning disability and what happens if this difficulty persists. Oftentimes, students are not diagnosed with LD until many years of struggle, and it's important that we get them the supports they need when it's most impactful, which is as early as possible. I'll now turn it over to Dr. Lerner to talk a little bit about AAP's mission and the work of pediatricians.
Thank you very much, Lindsay. Hi, everyone. I wanted to bring your attention to the American Academy of Pediatrics. It's a membership organization now with over 67,000 members, primarily pediatricians, and includes general pediatricians, subspecialists, pediatric surgeons. Our goal is to support the well-being and health for infants, children, adolescents, and young adults. And we have a portion of our organization who are board certified and thus are designated fellows of the American Board of Pediatrics. You saw that in my introduction slide with the FAAP. I wanted to briefly also speak about what we see as some of the different roles for pediatricians. You can see here that many families engage with us in different fashions. We may be working with families during general health visits to work preventatively. That may include providing immunizations or monitoring growth, nutrition. Early recognition is a second consideration, and I think that that's central to the discussion we're having day. We'd like to try and recognize, and through our own efforts, but also the efforts of our community, to meet the needs of children, whether that can be to ameliorate, to reduce the impact of a health or developmental concern, or to provide direct treatment. We need to have a system which allows us to be able to engage with others within healthcare, but also within our community. The pediatricians often identify themselves as being part of a medical home. That's the pediatrician, the nurses, the team members who are working together within the office, but also the healthcare system that they have established. I think it's important to recognize that as possible, the quarterback of a family-centered medical home are really the patient and their family members. We are assisting them, including our primary care environments, but also as needed for their wellness, to be able to engage with specialists, with hospitals, with community organizations that may be able to meet basic needs for opportunities to be physically active on sports and other things that help to support the wellness of children. This also includes mental health systems of care. So we are hoping to assist families as they need to move both within healthcare as well as within their communities to support their children's.
Yeah, thank you, Dr. Leonard. So one of the things that we're working on at NCLD is how to detect learning struggles early on. And so we've created what we call the LD checklist, Recognize and Respond. So this is not a test or a tool to diagnose learning disabilities, but it can help spot the potential signs of these. And it can be used as a tool to start the conversation with different providers, such as early educators, or general educators, or even medical providers. And so it's what we have, what the user can do is can go through and identify the grade that the student that they're thinking about is in, and then they can select different areas of difficulty that they might be seeing. So this could be attention, it could be social emotional skills, it could be math or reading, but it's important to understand that these are often intersecting, and we call these comorbidities. So if a child has a reading difficulty, it's highly likely that they might also have a math difficulty. And so it's important to select all the items that you might think your child or student is struggling with. Once you select the items, you'll get different signs or potential signs of learning disabilities that you can select. So if you selected math at the preschool level, you might get some items that look like this. We have little boxes here where the eyes are that give a little more examples to some of the complex items, and definitions can be found when you scroll over these highlighted sections. So once you complete the full checklist, you'll be able to download your specific results. You can share your results, or you can download the full checklist, which has all the indicators, all the signs, from pre-K all the way up to adulthood on these different areas of concern. And in addition, we have a Spanish version that you can download as well. Once you have selected those, you'll get resources based on your results. So if you selected pre-K through math, you'll be provided a host of resources that could support your child in pre-K math skills. So this is found on our website at ncld.org/LD checklist. In addition, there's questions to ask pediatricians and educators to get that conversation started, because we think it's important to have, like Dr. Lerner was saying, have a lot of people on the same page to support a child. In addition, AAP has a lot of great resources on their parent-friendly healthychildren.org website that I hope my colleague is dropping in the link now. So this has a lot of great resources on learning disabilities. It has definitions and potential signs as well, and a lot of great information for parents. But in addition, there's a lot of other resources, as you can see on the left-hand side, that focus on other health issues that are really important to consider when your child is young and growing and developing, and they might develop some of these conditions or illnesses. That there's a lot of great resources that healthychildren.org has. So with that, I want to turn it over to Sheldon to begin the conversation with Dr. Lerner to talk about the importance of early detection and ways in which parents, educators, and pediatricians can work together to make sure that that process is inclusive and we get the supports we need to children as early as possible. So Sheldon.
Thank you, Lindsay, and thank you, Dr. Lerner, for being with us. Fabulous to have someone from the developmental and behavioral pediatric community who is so expert in all things child development to share your knowledge, your experience, and just help think through and talk through and build awareness of what I think everyone would agree would be the importance of early identification of risk and early identification of problems that can be addressed, certainly in school-age children. We at NCLD have been very proud of the work that we've done in the LD checklist arena. The original checklist dated back, more than 10 years, 12, maybe 15 years. That was just a PDF printed version that we handed out at conferences and put in the mail to families. But this being an online version, we think that it really presents new opportunities. What we're not sure of, and we'd love to hear a little bit, maybe Mark, you can reflect on this a little. What's your sense about something like this checklist, using the checklist either before an office visit to build awareness of the kinds of things that parents may want to share with the pediatrician? Might there be an opportunity during the office visit itself? Or is this something that might be done after the office visit or in conversation with a pediatric provider, and then have families share back that information, those observations with the pediatricians and with educators? What do you think?
Thank you, Sheldon. I actually am excited about this tool. I think that pediatricians sometimes engage with families over learning issues during their well child visits or health maintenance visits, and other times because they may have been directed by a school nurse or a family member to come in and have a conversation about learning related challenges. Looking at the checklist, I think that it's one of the kinds of tools that I might direct families to after a visit if I needed to get more details down in anticipation of a conversation with school, or alternatively ask families to complete in the same way I might have families complete a checklist if there were concerns about attention and behavior. That would be one of the standard ADHD questionnaires, like a Vanderbilt questionnaire, for example, an ADHD rating scale. It would help me to understand the areas of contact that are within a child's learning experience that I would need to be thinking about. When we begin the conversation, we also have another new tool. Most families don't bring in a lot of background information, and that begins with their child's report card. But the great thing is now we're teaching young pediatricians to ask parents to bring up their report card on their phones if they have a district with an electronic information system and an app. And that will tell me things like attendance, and it will tell me teacher comments as well as completion rates for work. So there's lots of sources of information, but I think that the checklist it is certainly in its new form a very helpful new tool that we can integrate before or after visits.
Yeah, that's really, thank you for mentioning that. I think report cards and the comments section in particular on the report cards, even more so than grades, could be a really fabulous feeder of information and the kind of thing that could be followed up in conversation, both with pediatricians and educators and amongst other care providers.
I wanted to make one more comment if I could, which is that pediatricians do ask about a child's family, as well as should have an understanding of a child's health background. So when we're doing a visit, we certainly need to be considering active potential concerns. Schools will sometimes check on vision and hearing, but we have children who are not reading because they can't see the board, or they had glasses which have been lost, and that is unfortunately much too common. We also have children who may have had central nervous system stress. They may have been born prematurely, or who have experienced exceptional family stress that we know can influence the ability of a child's brain to focus and set priorities and to advance in learning. So all of that background information can be integrated with also knowing how have the parents done in school themselves? What's their educational attainment? What mental health concerns may, which have a genetic contribution, may also be present? Is there a family member who has a previous experience with ADHD or with a reading disability? Or are forms overwhelming for parents because of the reading and language content that are involved? So all of those may come into.
Yeah, that's a great point. I remember from work that I did when I was working in hospital-based evaluation and treatment programs, one family in particular that stands out in mind. We did an evaluation on a middle school age child. We presented the report to the family. The child was in the room. The father turned to me and said, "Is that a report on me or my son?" He very much saw himself in the information that we were sharing. And what's nice, I think, about the LD checklist is it just doesn't address pre-K, early grades, middle school, high school, but it really does extend up into the adult years as well. So it's another source of information that I think can be shared in meaningful ways. Which also brings to mind the importance of the language that we use, the ways that we ask questions, and how it is that we hook ourselves onto data and good information. Parents often worry about the stigma of having a learning disability or having an attention deficit disorder. And the stigma, I think, is something that prevents good conversations to happen, questions to be followed up on. But I think something like the checklist could be really helpful with that in that regard. Do you find often that it's a hard barrier to break, that stigma sometimes gets in the way?
I think it's an important concern, and often it's the hidden element that leads in a delay to getting children to sources of help. We are trying to train young pediatricians to make sure that when we talk about aspects of development and behavior, that we're asking permission and we're using appropriate language because of the potential for stigma. And families can communicate with us about their comfort zone. There's more than one way to talk about a child who may be having problems with focusing and academic productivity, for example, or a reading frustration or a language communication frustration. So we can make a decision to sometimes activate traditional health language, like diagnoses, medical diagnosis being different from an educational eligibility or different from how things are talked about in school. But we may need those terms to activate billing and access to support services. But we can still teach families to talk about their child descriptively, to say, my child's focus, or being able to be still and think, or being able to take their words from the page to be able to think about them and then be able to explain what's gone on. And so descriptive approach as a comparison to a diagnostic approach may be more valuable. Families, also sometimes we just have to go slow. We have to stay in that domain and not slow things down. The American Academy of Pediatrics has made a commitment to the process of early detection by passing out to our national community guidelines on early screening. So we begin with screening tools, even at 6 months of age and through the start of preschool, where we're asking about developmental considerations, including features of autism spectrum disorder, speech and language, motor skills, and social and behavioral concerns. That may include evidence-based tools like the Ages and Stages questionnaire, which is in its current iteration, I think Ages and Stages 3, or other tools which are recognized to be adequate. That doesn't mean that pediatricians are mental health providers or that we are educators, but it helps us to understand when we need to activate some of those connections through the medical home.
Yeah, I think that's really critically important. And what resonates with me in particular from what you just shared was conversations that I've had over the years with parents in education settings, with teachers also, who say, well, I'm not a special educator. I don't know what I'm looking for. I don't know if what I see is really a problem. I had the privilege of working with a developmental behavioral pediatrician who serves on our professional advisory board. Last year, we actually published an essential guide or essential skills guide for struggling learners. And it was all about observation. It was all about how to look across, as you said, vision and hearing and motor skills, thinking about language, thinking about readings, thinking about math, but also thinking about emotional regulation, thinking about affective kinds of things that are very much diagnostic, even predictive in some ways, of kids who are going to have those kinds of problems. I think the developmental pediatric community, pediatricians, and the relationship they have with families can be of a major important indicator or a pathway to discovering areas of need, areas of concern, because parents are expert at looking at their kids and saying something just changed, or it wasn't like that last year. You know, they don't have to be experts in reading or experts in attention, but they certainly see changes over time. And now during the pandemic, that I think everyone would agree is exacerbated because so many families, so many parents and kids are in the same space watching each other and doing those kinds of things that would otherwise only have been perhaps first noticed by educators in a school-based setting.
I would agree. I'd also point out that early intervention can include an opportunity to reduce the negative impact of learning challenges. We know that there are ways to help children who learn to read differently, for example, and early intervention makes a clear difference. Certainly we see that with health concerns. We would not want a child to have an unidentified concern, which is masquerading as a poor focus, and yet it may represent a heavy mild seizure disorder. And there are certainly treatments for those kinds of concerns. But also children who are frustrated may experience secondary challenges because of their frustration, a lack of engagement, turning away on a diminution in their effort. So again, getting them help. And also parents need to hear messages about how to build up their children and to focus on their strengths as well as areas of challenge. And so that's another thing that we also would like to see pediatricians communicate. I certainly know, because of the variation from one child to another, that sometimes pediatricians can delay families in their search for help. And it may be because we come up against the sense of that wall of stigma, or we're concerned about it and maybe responding even if it's not present, so that we see that some medical in some medical visits, families may be told to monitor their child's progress when an intervention is appropriate. But what we've been trying to teach, in the same fashion that when we have a child who will not cooperate when we're testing their vision, that may be because they can't see, not because they're just not cooperating. And that advances them in our protocols to seeing a children's ophthalmologist who can assess with reduced cooperation. In the same fashion, we do feel that we should be listening to parents, as you said before, Sheldon. They know, and that their concerns should be activating systems of evaluation and support.
Yeah, I think also something you mentioned triggered the thought that the relationship is so important. I know, having had two of my own children, had close connections with pediatricians who were managing and monitoring some of their health needs, but also their behavioral needs. And the pediatrician was really an ally, not just to me and my wife and my family and my community, but my kids really thought that they were expert. They really knew something about them, and they trusted them, and they liked them, and it made them feel okay talking about, for example, their ADHD. Um, you know, the pediatrician helped him find some language that made him feel in the driver's seat, that then helped build confidence and allowed him right through his college career to be a self-advocate, a really robust and strong, confident young man. I think it's the relationship also with the pediatric provider that could be so powerful.
It's one of the reasons we hope to, it's one of the reasons we hope to have ongoing relationships. I had a dad who approached me. I was doing primary care part-time in a university setting. One of the professors approached me and he said, how long are you going to be here? Because, I see people who advance and they change from an assistant to an associate professor and they leave. But we'd like to be in an ongoing relationship with our pediatrician. And so I can tell you I did have a chance to continue with this young man through his early childhood, through his college years. I've been sort of a homebody and haven't left my university in over 30 years. So I'm more than met my commitment to his longitudinal care, but it's part of the satisfaction, and certainly it adds to trust.
Lindsay mentioned that long word comorbidities. I like to refer to them as co-occurring behaviors or co-occurring kinds of concerns. I know you as a pediatrician see these kind of things all the time, and part of your responsibility is to rule in and rule out co-occurring conditions. What you see is not always what you get. But now that we've been entrenched in all things COVID for the last year, I think that comorbidity question, the issue of competing and overlapping issues that compromise learning and attention, have become much more complicated. I can think off the top of my head, kids not having social contact for almost a year, not having access to the lifeline of special education and or related services, issues of healthcare in general, mental health care perhaps in specific, and even things like nutrition. Could you just reflect a little bit about these unusual times, and the additional burdens that maybe that families and children themselves are facing, and how pediatricians might be able to be part of the solution?
Now, it is such an important area. I saw an interesting statistic yesterday. In some national screenings, some national polls, prior to the pandemic, about 13% of adults had acknowledged significant mental health challenges, and now that number is 41%. So more than tripling of that number, and that's certainly true for children as well. And so we in pediatrics have had to take on a learning curve about the novel coronavirus, about the way in which it presents and its more complicated manifestations for particularly our pediatric hospital colleagues who are caring for children with what's called multi-syndrome inflammatory disorder. And yet we are so grateful that so many children have not experienced severe health complications, as unfortunately we've seen in adults and particularly the elderly. But the considerations of what's happening from coronavirus do relate to the baseline levels of stress, which are part of a child's life, which can contribute to concerns. We know that children experience a pandemic as an adverse childhood experience. This slide here talks a little bit about the predictors of child health outcomes, and that includes learning outcomes. And so, yes, while there is a heritability, a genetic contribution through genes or through the a genetic code to one's risk of ADHD or certain types of learning styles, we also realize that the resources of one's community, access to food, access to support, but also the stress moments, which may be part of an environment with an unsafe walk to school, or a parent who is managing on his or her own due to incarceration of their partners, parent mental health, physical abuse. All of those add to diminished academic advancement. And the pandemic is another of those stressors. It can contribute to features of post-traumatic stress disorder. And that's why we have resources on the American Academy of Pediatrics website about supporting families through these times. I wanted to mention briefly, and we could probably move to the next slide, but I wanted to briefly mention a little bit about the language differences between education and healthcare. You mentioned the term comorbidity. I wanted to briefly touch on the term differential diagnosis. The term differential diagnosis in healthcare might be those different conditions which may mimic each other and create an observable change in a child. I mentioned that before for the child who may be having a staring spell seizure, and yet alternatively, it might be a child who was having problems with focus, or a child on the autism spectrum whose mind goes to a favorite topic and they're supposed to be listening to their teacher. Thinking about those is a differential diagnosis trigger for me as a healthcare provider. But for teachers, that may be, how do I put together the approach to assisting a child with a slow progress in reading? I've heard the same term utilized to talk about the reading in curricular tools or systems of instruction that may be utilized. And comorbidities or coexisting conditions in pediatrics can reflect a group of children who may have a learning impact of their health difficulties. That can happen to the increased risk of reading concerns in children with type 1 diabetes, or difficulties in children who have developmental and brain conditions like the skin birthmarks of neurofibromatosis associated with learning-related concerns, or genetic disorders that may impact overall learning or specific academic subjects. So that's a little bit about what we think about. That's different from the eligibilities, which is that gateway that a school team, along with parents, create when a child has a significant learning challenge. You have to pass through that gateway in order to receive school district associated services. Many children who need help are not deemed far enough behind to get help through the school district. But sometimes one of the sources of support might be through the medical home concept, through referral, through health insurance, to a speech and language pathologist, or an occupational therapist, or through a community referral to an educational specialist. There are even pediatricians who have included educational specialists in their practices, along with mental health colleagues who may be associated with a multi-physician practice. So some of the comfort of being within a known medical environment may allow families to move into needed care, which is not traditional health care.
So important. I think one of the things that we hear all the time is that parents often don't know what they're entitled to. They don't know, for example, that they're allowed or they should be encouraged to include a pediatrician or another care provider in conversations with the Committee on Special Education when they're looking for opportunities to have their child evaluated to see whether or not they meet those eligibility qualifications. NCLD has a parent's guide to IDEA. It's free and available on our website, and it walks through some of those pre-referral services, what it is that parents should think about and look for, what kinds of information are important to share, and very often those are very much connected to the very same questions that you've been asking about medical conditions, risk factors that may overlap categories. So that's another guide, another opportunity for parents to sort of step in and be ready for those conversations in meaningful ways.
I would add, God willing, as we pass out of this, acute pandemic state, that this will be a disruptor, and we will have new opportunities in new systems. And I know that few pediatricians participate in IEPT meetings. It is done by some specialist pediatricians, but it's not common. And yet it may be helpful with parents' permission to have a dialogue back and forth, and the use of telehealth-related resources, which have grown so dramatically. And even the ability of pediatricians to be able to consider their participation with a family, a billable telehealth visit may allow for engagement with pediatricians who might then be able to bring their voice in. Certainly, pediatric medical diagnosis can support eligibility for a 504 plan for children who do not qualify for individual education plans. And being able to have questions and answers go back and forth, I think, can be helpful. School districts are hesitant to direct parents to services, in part for fear that if it occurs within a team meeting, that they may be responsible to pay for it. And we know the healthcare system is available and is ready to provide services, but we may not be called upon because of that barrier, being concerned that it would become a school district obligation. So having us as being part of that conversation from the start or from an IEPT meeting moment, I think maybe helpful.
Yeah, I think it would be wonderful if we could aspire to a time where there was that parent pediatric school professional partnership, and it was sort of baked into the way schools do business and pediatricians think about opportunities, and parents, as perhaps the glue that holds that all together, could be really strong and mindful and effective advocates for their children. Okay, we have a few minutes. Are there any questions that we would like to address?
Yeah, and I will add that if we don't get to your question, feel free to email us at info@ncld.org, and we're happy to provide information there and try to answer any questions that we don't get to. I think one of the first questions we have is more on the advocacy front, and I think this is from Dr. Lerner. We got this earlier prior to the webinar, and one participant asked, how do they get more involved with pediatricians in terms of advocacy efforts, particularly at the state level, if they want to get pediatricians on their side to promote early screening or something like that?
So what I would encourage you to do is to go to the website and look for the chapter of the American Academy of Pediatrics for your state. Except for New York and California, in part because of our large size and some idiosyncratic history, each state is one chapter. And typically you'll be able to identify the executive director, the leadership of the chapter, and often even the advocacy lead. Here in California, we do have 4 chapters, and we run a state government affairs committee, representatives of each, and we monitor legislation for children. We try to work with specific legislators to promote priority issues that we think are important for children. We've had some fairly visible work in California, for example, on immunizations and folks who are not immunizing their children. But also, our state has had advocacy work that has been done by educator leadership, which has helped to develop specific language learning disorder or dyslexia as a California-specific eligibility within our state special education. So working with your chapter of the American Academy of Pediatrics in your state is the best initial contact.
Great, thank you. And so another question I think is just a little more fundamental that I think both you and Sheldon can answer is, what is the screener, like what is some examples that a pediatrician might ask, like that initial evaluation, not evaluation, but initial questionnaire in a doctor's office to think about and start discussing possible learning difficulties? What would you ask a parent if you thought that they might think their child is struggling in a particular subject?
Before Mark answers that question, I would want to reframe it. What would the conversation look like, both with the parent and with the child? Because I can't tell you how many times the parent will say, my kid is not doing well in math, and the kid says, no, I'm doing fine in math, and then explains why the parent might think otherwise, or vice versa. So keeping the child in the conversation, keeping the student in the conversation is really so very important.
I would certainly agree. I think that as children are heading, so as I mentioned, we would be asking about parent concerns in general. Again, we have a fairly chock full 20 or 30-minute appointment to talk about nutrition, to measure growth, to talk about the potential benefits and side effects of immunizations and things of that sort. And that's where we might be taking a look at the results of a screener that a family has finished in the waiting room and has been scored, so we can address how things are going. And if things appear to be going well, to say, thank you so much for completing the paperwork we gave you about learning and behavior. And it seems like everything's on track. Are there any additional concerns or issues you wanted to bring up that might not have been covered in that item? Or how are things going in school? Or are you able to get to school on time? And, are you going all the time? Or can I see your report card as a start? I think that all of those are opportunities. Pediatricians don't use a standard school-aged screener. But one of the things we try to do very early on is we introduce books to children. Many pediatricians are involved with an AAP-supported activity called Reach Out and Read, where free books are given to children who are vulnerable beginning in infancy. And we begin to talk with parents about how children can engage with the book as a physical object and be read to, and to watch their attention and engagement. And when we may take a bit of time as we introduce the book to read to the children. And we have a chance to be able to use that as an engagement, as a learning opportunity and a modeling opportunity. So those are some of the kinds of examples that come to mind.
Thank you. And I want to be cognizant of the time. I know we had set out around 45 minutes for this webinar. And I do want to say that, again, if you have any additional questions, that you can email us at info@ncld.org, and we'll try to address those there. And if there's common questions, we'll try to put out a more common, maybe on our YouTube page, we'll try to include the answers to some of those questions. And you can also ask the questions on the Facebook Live page, and we can answer those as well. I know my colleague Grace has been monitoring the Facebook, so there's been a lot of great questions that unfortunately we just weren't able to get to, but we hope to after the webinar. And I did want to highlight some of the resources that we mentioned during this time. AAP has a lot of great resources on learning disabilities and attention issues that you can address there, and I think we put in the chat the link to that. And then there's also a great COVID-19 resource page that AAP has developed that has a lot of really great resources for parents during this time. NCLD, like we mentioned, has the LD checklist. at ncld.org/LD checklist. And we also have some great COVID-19 resources that we've developed. So I encourage you all to go to those web pages. And feel free to connect with us on social media. Here are our social media handles for Twitter, Facebook, and Instagram, as well as AAP's social media that I'm sure that they'll be more than happy to engage with you on different areas that they cover. So again, thank you so much for joining us. Thank you, Dr. Lerner, for taking the time to share with us your expertise and your great knowledge around learning and attention issues and behavior issues. We really appreciate you taking the time and for allowing us to pick your brain a little bit. And thank you, Sheldon, for your expertise and great moderation skills.
Hey, thanks everybody.
Thank you again.